think you're still up here slinging bullets, Tirone. The next talk is going to be the Commando Procedure with reconstruction of the mitral annulus. When and how do I do it? By Dr. Piroze Davierwala.
Good afternoon. It's a pleasure to be here, especially when there's a tribute to one of your mentors from whom you've actually learned these operations. And I owe a lot to Dr. Tirone David, especially working with him for 2 years when I was a fellow 25 years ago. And I'm really happy to join him again 4 years ago on staff. So with that, I'd like to talk a little bit about the Commando operation. As you all know and have seen in previous talks today, it was pioneered by Dr. David. It involves aortic and mitral valve replacement with reconstruction of the intervalvular fibrous body with either a Dacron graft or a bovine pericardial or an autologous pericardial patch. So what are the indications and when do you need this operation? One of the commonest indications, at least where I was before in Leipzig, was endocarditis. Dr. David has a very vast experience of using this technique for calcified annuli and also for redo double valve replacement, because many a times there is no tissue left after excising both the prosthetic valves, and this is the only operation which can be performed in order to secure the two valves. And in some patients, especially those with rheumatic heart disease who have very small annuli, in order to prevent patient-prosthesis mismatch, again, a Commando operation, or what we commonly call in Toronto as the UFO, is required in order to get adequate size valves in the mitral and aortic position. So I'll be just showing you a couple of videos on the two commonest indications. One is endocarditis. When you see a valve like this, this is a prosthetic aortic valve with a large periprosthetic abscess. And as you can see in the echocardiogram below, there's a complete discontinuation between the aortic and the mitral annuli. In these situations, you usually end up with this kind of an operation. And the other patients that you commonly see is in MAC with severe calcification of the anterior annulus and the intervalvular fibrous body, as you can see here in the coronary angiogram and on the CT scan, where there's significant amount of calcification of both valves. So this is a video of endocarditis. This is a patient with prosthetic valve endocarditis. We are excising the aortic root. And you can see the prosthetic valve, which is a mechanical valve, can simply be pulled out without even cutting the valve because of infection, periannular infection. So we then try and excise, as Dr. Al-Khoury also mentioned again and again in his talk, that try and reach the normal tissues as much as possible, because that's the only way of doing these operations. So these operations usually end up with extensive excision of not only the aortic root, but also of the intervalvular fibrous body. This is the anterior mitral leaflet being excised. And if there is no abscess involving the posterior mitral annulus, you can preserve the posterior mitral leaflet. Once everything is excised, it usually results in one big opening of the left ventricle, and now we have to reconstruct the inflow and the outflow. So we start first with annulus sutures being placed in the posterior mitral annulus from the left to the right fibrous trigone. And you can see at the right and the left fibrous trigone, we usually take an extra proline stitch, which is used to anchor the patch. So we usually use a folded pericardial patch. You may or may not cut this, and this is used as the anterior mitral annulus. So you can see the corner stitches. These are the most important stitches. The corner valve stitches as well as the proline stitches are passed through the two ends of the folded pericardial patch, so that when you lower the valve down, the mitral valve prosthesis, the patch is anchored between the prosthesis and the native annulus so that you get a complete seal. We usually call these the corners of death because if you have leakages at this point, it's very difficult to address it, even if you're on pump. So the next step is to form the anterior mitral annulus. We stitch the two-layered patch to the anterior sewing cuff, and then we split the patch. The posterior part of the patch forms the roof of the left atrium and closes the roof because we cannot directly close the roof in this procedure because of the tension that would develop. And the anterior tongue of the patch then forms the left ventricular outflow tract and the non-coronary sinus of the aorta. And once this is done, then you can perform the aortic procedure, whether it's an aortic root or a standard aortic valve replacement. So these are the pledgets which are being placed for the aortic valve replacement. In this case, an aortic root replacement. And I usually take a double-layered bovine strip in order to anchor the non-coronary sinus. I won't show the root replacement because it's a standard root replacement once this procedure is performed. There's a second video which I will show you is annular calcification of the aortic and mitral valves. This was a 78-year-old lady with severe aortic stenosis and mitral stenosis with severe calcification, the CT which you saw previously in the previous slide. So as you can see here, we are excising the aortic valve. You can see it's heavily calcified, but you will soon see that the intervalvular fibrous body is also completely calcified. We were hoping to sort of strip it off, the mitral valve, but it was impossible to do that, and therefore we decided then to go ahead with the Commando operation. So here you will see that we open the roof of the left atrium towards the pulmonary artery posteriorly, and then move anteriorly towards the anterior mitral annulus through the intervalvular fibrous body and cut through the calcium. So here the anterior leaflet is again being excised, and then we move onto gradually from the aortic valve onto the mitral valve annulus, and as the posterior annulus was also completely calcified, it required decalcification of the posterior annulus as well. Since I had learned this technique from Dr. David, I try and perform this operation exactly the way he had taught us by using the 15 or the round blade, and the main important step is that the knife should be absolutely on the calcium so as to prevent any kind of injuries to structures posteriorly. You try and excise as much calcium as possible, and in this case, because it was very deep, you can see the epicardial fat on occasions. And once you have excised all the calcium, then you have to start the reconstruction of the posterior mitral annulus. Here is the medial side of the calcium being excised. And then you start placing the pericardial patch, as Dr. David had already shown in his in the talk this morning. You try and go as deep as possible. And again, as he mentioned, that you have to be very careful about the trabeculae, that you get a good seals. If you have any doubts about certain areas of the patch, then you can reinforce these areas with pledgeted sutures. So what you do is you try and take a U-shaped patch. I usually prefer to start at the bottom of the deepest point and move upwards towards the annuli on either side. And the most important thing is when you pull the patch down, you do not parachute it down like you do in a coronary case. You have to individually pull each loop, because trying to parachute it down without carefully pulling each loop can also cause a tear in the suture line, because this is all through muscle, and muscle is not as strong as as fibrotic structures. So you try and do it one loop at a time. So once the ventricular part is over, then you proceed to the placement of the mitral valve sutures into the posterior annulus. So I take a very small bite of the atrial lip that is left and then pass it through the patch. The important step here to remember is not to make the patch too tight. You have to keep some amount of redundancy in the ventricle, because if you pull it too tight, then it can also cause a ripping of the patch. So once all the sutures are placed, again in this case from one trigone to the other, you follow the same steps. The last suture that is placed on either side, or the left and the right fibrous trigones, are used to pass again through the second folded patch that we will take to perform the actual commando operation. So here you see how it looks once the posterior mitral annulus is reconstructed. This is the Prolene stitch that I showed you before. I take an extra Prolene stitch at both the medial and lateral fibrous trigone, which is also helpful in using which is used in order to suture the patch to the anterior mitral annulus. So here the stitches are now being passed through the bioprosthetic mitral valve, and here you can again see the trigonal sutures are passed through the patch and then through the valve at both the corners. And this is now the Prolene stitch which is being passed through the corners. Now in this case, before you parachute the mitral valve down into position, it's preferable to suture the atrial side of the posterior pericardial patch, because after the valve is sutured down and fixed, it is very difficult to take stitches. So here it's much easier with the valve still in the air in order to take these sutures through the left atrial wall. And you have to be a bit away higher up in the atrium in order to avoid the circumflex artery. So once this is fixed, then you can parachute the mitral valve down into position and secure it. And you can see how the patch also moves down with the valve and is sandwiched. The important thing is to sandwich this patch, the corners, between the sewing cuff of the valve and the native mitral annulus. So once you fix this, then we again run the anterior suture line, fixing the folded margin of the pericardial patch to the anterior sewing cuff. Once that is done, again, the operation then becomes pretty much similar to what I showed you in the previous video. Here we are suturing the posterior tongue of the patch to the left atrial roof, margin of the left atrial roof, in order to complete the closure of the left atrial roof. You should try and not keep it too redundant, because that pushes the mitral valve anteriorly and can cause some degree of left ventricular tract obstruction. So this part, the posterior patch, has to be just adequate in order to avoid LVOT obstruction. And once that is done, the anterior patch is now being sutured to the aorta and the LVOT to form the left ventricular outflow tract and the non-coronary sinus. So this is the roof which is complete, and here you see the anterior tongue of the patch, which will now be used in order to climb up the LVOT and the aortic wall. And then you can again perform a standard aortic valve replacement in this situation. These are very complex operations with a very high, they have a higher mortality than a normal double valve replacement, but in most cases, this is the only option that is available, and it is a good option to have in your armamentarium if you land up in complex cases requiring this operation. With that, I'd like to thank you for your attention.